Thank you, everyone. My name is Osman Dar. I don't have any slides to present today, sort of like Ramanan. Unlike Ramanan, though, I'm not succinct or polished in my manner, and I tend to ramble a little bit, so just bear with me for 5 or 6 minutes, and then the pain and agony will soon be over. So I'm going to talk a little bit about so I work at Chatham House, at the Center on Global Health Security at Chatham House, and this is a center within the Royal Institute of International Affairs. So we tend to frame global health issues like antimicrobial resistance from that perspective. So really these are just some reflections on some of the backroom dealings and actual framing of antimicrobial resistance, an insight perhaps into some of the levers that drive policy at both a global and a national level. And these are just some personal reflections that I've encountered over the past few years, having worked a little bit on antimicrobial resistance and One Health more broadly. So let's just break this down into perhaps some of the challenges I see or we see at the center going forward, and some of the opportunities that we're sort of aware of and involved in. In terms of the challenges, I think one thing is the framing of the issue. Now, great success has been achieved over the past few years in the global framing of antimicrobial resistance. And much of that success, in our view, has been down to framing it from a risk and a security perspective. So in a sense, securitizing the whole issue of antimicrobial resistance. But while this has been successful in bringing the issue to the fore and sort of really making it prominent in the minds of certainly Western politicians, there is a risk around sustaining interest, particularly in low and middle income countries. And that's perhaps reflected through our experiences in joint external evaluations, in national action plans for health security. When you actually go into the countries and meet with national stakeholders and really start to tease out what is it that's driving your interest in AMR and why you actually taking part, you start to see perhaps not what you'd expect as the reasons for staying engaged. Now from a UK perspective, I think we sort of launched the UK AMR national plan last week. The Secretary of State launched it at Davos. But if you look at some of the language that was used, so for instance, comparing the risk of global AMR to climate change and then war as well. I mean, depending on which country you're from, if you're from Syria or Yemen, I'm sure you wouldn't think that it's as big as a problem as war from a global perspective. There's an inherent risk in that sort of framing, and then sustaining interest, especially when you go into low and middle income countries, becomes an issue. So, for instance, when we go into national countries and we talk about the risks of AMR, a lot of the comeback is around the issue of access. So the first thing that you'll hear back is that actually, in I don't know, rural Central African Republic, do you really think that there's sufficient, that there's even enough access to antimicrobials in rural areas for you to even start a conversation around resistance? Is it even appropriate to do so? So perhaps one of the solutions to that is being able to contextualize and frame the issue in the correct manner, depending on where you are. And I'm sure this will probably be playing out at a subnational level within India as well. So framing it around access to effective antimicrobials rather than a risk-based framing of it is perhaps more appropriate, because there's endemic diseases and infectious disease outbreaks that are occurring all the time anyways in these settings. And it's the same with when you're sort of dealing with the animal health community. So we've heard a little bit about the great work that's been done in trying to bring the members of the tripartite together around an issue like AMR. And the tripartite's been around for 25 years, and there's always been institutional rivalries between the OIE, the FAO, and WHO. But really around AMR, they were able to coalesce a little bit. And frankly, a big part of that is that there was funding available that was being apportioned to the 3 different institutions to advance that process. But really, if you want to sustain it beyond that sort of injection of funding, you have to look at what the institutional and global needs for that sector are in that area. So, for example, around animal health, if you're truly interested in antimicrobial resistance from a global perspective, you would include diseases or consideration of diseases like, for example, African animal trypanosomiasis. Right? It's a neglected tropical disease, but it affects sort of 40 countries across sub-Saharan Africa. We know the rates of substandard or counterfeit use of trypanosides is between 40 and 70%. It's responsible for, you know, estimates of 50% of loss in milk and meat production in some of the poorest countries across Africa. But it'll never make it onto the framework for, you know, an AMR strategy, even if the animal health sector is involved, because fundamentally a lot of this is being framed around risks, and a lot of it is being framed around risks to wealthy nations. And so that is and I'm not saying this because, you know, I'm trying to be awkward, but that is the feedback we get at a national level from stakeholders in these countries. And it's very difficult to sort of argue against that then, because, and why should you argue against it, frankly, it's true. So I think those are some of the, that's one really important challenge. And I think, like I don't have a great deal of experience within India at a subnational level, but I would imagine that you would start to see some of the same kinds of concerns that, you know, are we really framing this around our national or sort of regional priorities? And these things are always about opportunity cost. And it's the same in terms of economic incentivization for developing new antibiotics. Now, we were part of a very big pan-European project, well, pan-global project called Dry Baby, which Alison too was part of. And one of the interesting notions within that was, it was about trying to develop new economic models of incentivizing antibiotic production and creating sort of new antibiotics. And one of the interesting things within that was that across Europe and North America, the actual absolute increases predicted between now and 2050 of sort of increased morbidity and mortality around antibiotics is not that high. So there's not that much of an incentive for drug companies to create and produce these new antibiotics. Furthermore, we for instance, like the O'Neill report and Dry Baby, and there was another big report done by Boston Consulting Group. They estimated that to incentivize pharmaceutical companies, you need between 0.8 and 1.3 billion dollars a year as a market entry reward to even bring companies into that market and start considering it. And then at the end of that, you might sort of start getting 2 to 3 antibiotics over a sort of 5-year period. Am I getting this right, Alison? Yes. So it's broadly around, those are the kinds of figures we're talking about. But there was little analysis done around return of investment in terms of antibiotics compared to other drugs. So a company might invest that much money and make a little bit of a profit. But why would a company invest that much when the return on investment on NCD drugs or chronic, you know, other chronic disease drugs or cancer drugs is of a magnitude 8 or 9 or 10 times higher? Why would you take the risk of doing that? Okay, you might make a small profit on some antibiotic through a market entry reward, but you're going to make so much more money on a chronic disease drug. Why would you do it? So reform of that sector requires wholesale reform around intellectual property, around, you know, broader visions of perhaps capping the maximum price that drug companies can pay, sort of like we're doing with utility companies here in the UK. You know, there's a price cap on how much they can pay now. But until that's the sort of thinking that you apply towards pharmaceutical companies, you're unlikely to make much progress. So that's just another issue around the framing. And again, while there's a lot that can be done at the global level, fundamentally these are issues of sort of national interest. And you can see that by the sort of retrenchment of a lot of powerful countries from sort of UN and multilateral organizations. our friends across the Atlantic, for instance, just on the issue of antimicrobial resistance, in December just approved the use of antibiotics for spraying citrus fruit, right? Ramanan, did they bring that up at that advisory meeting? So they're going to be using tetracyclines and streptomycin for spraying citrus fruit across the whole of the southern United States, from Florida to California. And the estimates are that there's going to be more tetracycline and streptomycin used in spraying, in stopping this. It's called citrus greening. I'm not sure what the disease is, but that's what it's called. And there's going to be more tetracycline and streptomycin used in spraying that than in use in all of human health in the United States. So that's the sort of those are the sort of economic forces that or headwinds that are coming, that are going to be facing this community that we're all a part of in terms of antimicrobial resistance and its control. So our view is that certainly from a low middle income country perspective, the entire framing of the issue should be around access to effective antimicrobials, with AMR being one factor amongst a number of others in limiting that access. Others being, substandard and counterfeits, drugs which are themselves a driver of antimicrobial resistance. So that's one thing. In terms of some of the opportunities, because I'm probably running out of time and I'm starting to ramble. In terms of some of the opportunities that we're working on through Chatham House, we're involved in work around SDG 2 as well, which is around ending world hunger, addressing malnutrition, and there's some interesting insights from SDG target 2.3, which is about doubling agricultural production. Now, a lot of you will know that there's a huge foodborne disease burden across the world as well. I think 600 million sort of infections, 420,000 deaths a year. Many of these in Southeast Asia, and alongside, and while this is happening, that's the situation today. But over the next 15 years, the aim of target 2.3 is to double agricultural production, and alongside that, there'll be a huge increase in needs around food safety and food surveillance. So there's a real opportunity there for the AMR community to perhaps get involved in some of that work and address some of the issues around food safety. A lot of investment will be going into that side of things. The World Bank estimates that foodborne diseases cause a burden of about $110 billion a year, and they themselves are going to be investing about $25 billion in upgrading food safety systems. So that's a real opportunity for the AMR community to leverage some of that investment and sustain the interests that have been generated through Dame Sally's work and others in the room on bringing AMR as an issue to the fore. So that's one opportunity. Because this was India, and I heard some reflections over the day around religious gatherings. The Kumbh Mela it's a unique event in terms of any religious mass gathering in the world. You can have up to 100, 120 million people in one area of a 2-week period. Think of the opportunities in terms of health promotion, in terms of a captive audience that can be with religious leaders there that have great influence over swathes of people. So much great health promotion work could be done around AMR. You could create all kinds of cohort studies and model where people are moving and taking their resistance genes with them. A lot of great innovative thinking can go into that, and it's a real opportunity that's perhaps unique to India, at least on a domestic front. Of course, India sends a huge number of pilgrims for the Hajj as well, so there's probably 180,000, 200,000 people a year contributing to, again, sort of the biggest religious mass gathering in the world, which has in itself probably 2 or 3 million people, and that itself is a factor in the distribution and movement of AMR and other infectious diseases around the world and the distribution. So again, there's a big opportunity around leveraging are developing research studies and cohorts of studies. And the reason I raise this is because, so I also work as part of Public Health England. We have a center on mass gatherings medicine at Public Health England. It's a WHO collaborating center. And we recently, a couple of months ago, had a first symposium on religious mass gatherings. It's a real opportunity, I think. And you know, I mean, from the quality of the presentations this morning, this afternoon, there's a lot of smart people in this room. So, you know, I'm sure there's a lot of really interesting studies that could be done. And we have Dr. Shuja Shafi and Dr. Ali Zumla here in the audience. So if there are people that want to do some work around religious mass gatherings and developing some studies there, then certainly speak to them. The third opportunity that I was going to talk about is that I think there's been a real movement and impetus around One Health approaches to antimicrobial resistance. And there are, you know, sort of joint research opportunities now. And for instance, we're part of the Pandora network, which is an EU-funded project, which had specific instructions of around having to collaborate across human, animal, and environmental health it was a condition of the funders to carry out that research, and I think a number of funders are starting to think in those terms that you know you have these sort of multidisciplinary approaches. So I'll stop there because I'm sort of losing my. Okay, there you go. See, I'm starting to mumble now. So fine. So thank you very much.